Welcome back to My Hematology. This is where we take complex concepts of hematology and break it down to simple bite sizes for easy understanding. Today, we're going to have an overview into the core pathophysiology of hypochromic microcytic anemia. So, if you've ever stared at a CBC report and wondered how to systematically approach those low MCV and MCH numbers without totally second-guessing yourself, you're in the right place. Let's decode the underlying causes together. Here's a quick look at our clinical roadmap for this explainer. We'll start by defining what's hypochromic microcytic anemia. We will move through iron deficiency and chronic disease, thalassemia, sideroblastic anemia, and lead poisoning, and finally wrap up with the diagnostic approach and synthesizing that differential. All right, the absolutely crucial first step is defining our terms with lab values. Microcytosis simply means abnormally small red blood cells, and we confirm that on a CBC when the mean corpuscular volume, or MCV, drops below 80 femtoliters. Hypochromia, on the other hand, means the cells look paler than normal under the microscope, and that directly correlates with a mean corpuscular hemoglobin, or MCH, of less than 27 picograms. Whenever we see these two specific values flagged low on a lab report, our differential diagnosis should instantly narrow down. A good way to visualize this is to just think of red blood cells as little biconcave bags of hemoglobin. Hemoglobin is that vital protein that not only carries the oxygen, but also gives the cell its rich red color and its physical volume. So when hemoglobin synthesis is impaired, really for whatever reason, the body essentially builds a smaller bag with less pigment inside. And naturally, that lack of hemoglobin directly leads to reduced oxygen delivery to the tissues, which is exactly why the patients are going to be sitting there complaining of those classic symptoms, like profound fatigue, weakness, and feeling short of breath. First up on our suspect list is iron deficiency anemia, or IDA. We're going to see this a lot because it is the single most common cause of anemia globally. The pathogenesis here is pretty straightforward. Without enough raw iron, the body simply cannot synthesize the heme component of hemoglobin. The root cause usually falls into one of three buckets: insufficient dietary intake, impaired absorption, like in celiac disease, or chronic blood loss, such as from peptic ulcers or heavy menses. And aside from the typical fatigue and pallor, these patients might develop pica. That's a super craving for non-food items, like chewing on ice or even eating dirt. Now, let's contrast that with anemia of chronic disease, or ACD, which is sometimes called the anemia of inflammation. This one is driven by chronic systemic conditions. Think rheumatoid arthritis, lupus, cancer, or chronic kidney disease. While ACD is actually often normochromic normocytic anemia, prolonged smoldering inflammation can absolutely disrupt iron metabolism enough to cause a hypochromic microcytic presentation. But here is the major plot twist. The iron isn't actually depleted from the body. Instead, inflammatory cytokines like IL-6 cause the body to hoard iron, trapping it inside macrophages. This makes the iron completely biochemically unavailable for red blood cell production in the bone marrow. To easily tell these two apart, picture your body's iron stores as a treasure chest. In iron deficiency anemia, the chest is truly empty, so your ferritin, which reflects your iron stores, is going to be low. To compensate, the liver desperately sends out more transferrin iron claws to grab any available iron floating around. So your total iron binding capacity, or TIBC, is high in IDA. However, in ACD, the iron is locked inside the chest. Ferritin is normal or even high, but the TIBC claws are low because the body is actively trying to hide iron away from potential infectious pathogens. Now, let's take a look at thalassemia. Remember, hemoglobin isn't just heme. It also requires globin protein chains. Thalassemia is a group of inherited genetic disorders where specific mutations impair the production of either the alpha or beta globin chains. If the cellular assembly line can't produce the necessary globin chains, it literally doesn't matter how much iron you have on hand. The factory simply cannot build complete hemoglobin molecules. The end result is small, pale red blood cells presenting as hypochromic microcytic anemia. A ring sideroblast is basically an immature red blood cell precursor in the bone marrow that has a visible ring of iron-loaded mitochondria circling its nucleus. So in sideroblastic anemia and the incredibly rare IRIDA, which stands for iron refractory iron deficiency anemia, the iron makes it to the red blood cell precursor just fine. The real problem is ineffective iron utilization. The iron gets biochemically locked out of the final assembly line and just cannot be incorporated into the protoporphyrin ring to make heme. Instead, it just piles up in the mitochondria. This whole process can be congenital due to gene mutations or acquired from things like chronic alcoholism or even certain medications like isoniazid or chloramphenicol. And of course, we cannot forget lead poisoning. Lead is a highly toxic heavy metal that directly poisons key enzymes right in the middle of the heme synthesis pathway. It also physically shortens the lifespan of whatever red blood cells do manage to get made. Lead exposure causes severe cognitive impairments and developmental delays right alongside the anemia. So here's the big question. Whether it's iron deficiency, thalassemia trait, or early sideroblastic anemia, the patient is still going to sit in front of you complaining of fatigue and weakness, and they are all going to have a low MCV. So how do we cut through all that noise and confidently diagnose the true underlying cause without just blindly ordering every expensive test in the hospital? Well, we use a strict, stepwise algorithmic approach. Step 1 is always the clinical and family history. Are they having heavy menstruation? Are they strictly vegetarian? Step 2 is the CBC and a peripheral smear to visually confirm microcytosis and hypochromia. Step 3 is the critical pivot point, iron studies. Checking ferritin and TIBC will immediately separate your iron deficiency and anemia of chronic disease cases from the pack. And only then do you move to step 4, ordering targeted confirmatory tests like hemoglobin electrophoresis for suspected thalassemia, or a bone marrow biopsy if you suspect those ring sideroblasts. Let's bring it all together. By analyzing the patterns across these specific iron study parameters, we can reveal the exact cause. If ferritin is low and TIBC is high, we have iron deficiency. If ferritin is normal or high, but TIBC is low, it's anemia of chronic disease. If iron and ferritin are both high, you should be thinking sideroblastic anemia. And if all the iron studies are completely normal, but the MCV is consistently, stubbornly low, thalassemia jumps straight to the top of your differential. It is all about recognizing the pattern. Which brings us to our final thought for today. Imagine you have a patient sitting in front of you right now. The iron studies come back perfectly normal, completely ruling out iron deficiency and anemia of chronic disease. Yet their CBC shows profound microcytosis with an MCV of 65. What critical test must you order next to solve the case? That's right, you need a hemoglobin analysis, or HPLC, to confirm thalassemia. Keep this algorithmic approach right in your pocket, and you'll navigate these hematology mysteries with total confidence. Thanks for joining me on this video, and I'll catch you on the next one.